Hello, everyone. Thank you for attending the SpinePort webinar tonight to talk about the use of the SpinePort in a transcorporal microdecompression procedure. We have Dr. David Lowry on the call today. Dr. Lowry has been performing these procedures for many years and was very involved in not only founding transcorp spine, but also development of the SpinePort system. We are going to hold off a few minutes before starting to allow a few others to join us. But Dr. Lowry will begin in a few minutes. Thank you. Okay, David, why don't you begin? I know there's going to be a few other surgeons joining us. They're just running a little late, but why don't we go ahead and get started?
Making your time available. Thank you for making your schedules available for this webinar. I'll be discussing tonight transcorporal microdecompression, and we'll be running through a few cases. The basic goal, of course, of TCMD is a minimally invasive anterior approach, which allows us to both remove any osteophytes that may be present or disc material compressing and exiting root. We get the benefits of an anterior approach and not having to go through the paraspinal musculature, but we do not have to perform a fusion and do not have any hardware left behind, unlike an arthroplasty. We're able to retain motion without the need for a permanent metal on poly implant to do that. TCMD can be introduced in, I find, earlier in the continuum of care than fusion or disc replacement. Often to the patient, there's a perception of fusion or disc replacement as being unacceptably invasive for them, whereas they may find acceptable a TCMD procedure because there is not a permanent implant left behind, because there is not loss of motion, and because they are able to retain native motion with their own disc space, or natural motion with their own native disc space. We also find that the shorter return to work of a few days as opposed to several weeks is very attractive to many patients. This is a procedure that can be used in the anterior cervical spine. You'd have to go upward through the C3 vertebral body to reach C2-3, but in the standard approach that I've used, going through the upper vertebral body to address the pathology, so for instance through C5 to get to C5-6 pathology, using that approach you can very easily reach C7, E1, even in patients who seem to have otherwise difficult anatomy for that segment. I'll go through a few cases here. The first is one in which we did both an anterior cervical discectomy and fusion and also a TCMD. The patient was a 65-year-old man with right-sided C7 radiculopathy. He was found to have a weakness in the triceps as a part of the presentation. He was found also to be diffusely hyperreflexive, had long tract signs as well, and we found degenerative disc disease at C5-6 with severe central canal stenosis, and then the disc herniation on the right at C6-7, which is actually what brought the patient to medical attention. We performed at C5-6 a single-level anterior cervical discectomy fusion, and at C6-7 to address the soft disc herniation, a TCMD procedure. In doing it in this manner, provided the patient with the relief that he sought, while also taking away motion at one segment only at C5-6. The reason a two-level TCMD procedure was not considered is that the patient did have severe central canal narrowing at C5-6 that did extend into the foramina as well. So this patient did not have pathology that we could have addressed with a midline TCMD guide at C5-6. The pathology was simply too extensive at that level. Here we can see some radiographic images. You can see at C5-6 the decrease in disc height, some hypertrophy of the ligamentum flavum at that level, as well as a broad-based disc osteophyte complex, and at C6-7 the soft disc herniation on the right. This, of course, shows the patient with it looks like a allograft interbody implant at C5-6 and then an anterior cervical plate. You cannot see well on that lateral view the shadow of the beta tricalcium phosphate from the TCMD procedure that was done, but I think it's hiding behind the shadow of the screw. Note that we were able to achieve dramatic improvement. The patient's arm pain went from a visual analog scale score of 9 pre-op to 0. The neck pain went from a VAS of 8 to 0. And we were able to get him back to work in 6 days as well in this situation, even though we did do a fusion as well. So the patient responded quite nicely. The second case I'll discuss with you is a TCMD used as a standalone procedure. In this situation, a 56-year-old patient presented with gradual onset neck pain, but also radiating left arm pain in the C7 territory. She was found to have a broad-based disc bulge at C6-7 and superimposed upon that an acute foraminal disc herniation on the left with resulting impingement of the exiting left C7 root. The procedure chosen for this was a standalone TCMD procedure. I felt comfortable offering this to the patient as even though there was a broad-based bulge of the disc material, the primary concerning symptom for her was related to the C7 radiculopathy, and TCMD was very effective in addressing the complaint that brought the patient to medical attention. Here you can see the loss of the usually lordotic curvature of the cervical spine, broad-based bulge at C6-7, of course not severe enough to obliterate the cerebral spinal fluid ventral to the cord, and on the left side we did find a foraminal disc herniation. You can see here, of course, the preoperative cervical radiograph and the postoperative radiograph. Note that on the postoperative film, the patient is assuming an improved curvature. There's less of a kyphotic deformity being shown in the cervical spine. I suspect that she was perhaps in part holding the foramen open volitionally or even subconscious level because of the severity of the compression on the root. The reversal of the usually lordotic curvature of the cervical spine is not at all a contraindication to doing the procedure, in my view. And this patient also did quite well. The arm radiating VAS score went from 6 to 1 at the 1-month post-op mark and went to 0. I'll mention that from the standpoint of timing, we do typically see immediate relief of the radiating arm symptoms in these patients. We're showing a 1-month figure, but just as with arthroplasty or cervical fusion, we see immediate relief of the radicular symptoms either in recovery or by the morning post-op. We have the same experience with this procedure. The patient's neck pain, of course, was a VAS of 10 preoperatively, and that improved very well. And you'll note that the patient returned to work at the 5-day mark. Both the neck pain and the radiculopathy improved with TCMD, and the neck pain improved despite the loss of the lordotic curvature. I'll mention here that I did not see her neck pain as precluding this procedure because the crescendo in the neck pain did seem to come around the time of the onset of the radicular symptoms. And so I was confident that we would get some relief of the axial pain as well. The third case I'll be discussing is one involving a 58-year-old woman who had neck pain and also experienced bilateral shoulder pain. We found that she did have a loss of the usually lordotic curvature. She had degenerative disc disease at C4-5 with advanced spondylosis. She had an anterolisthesis at C4-5 that increased in flexion, and she was also found to have at the C3-4 level, one level cranially, severe foraminal stenosis on the left. And so we elected to do a single level fusion at C4-5, but to address the foraminal stenosis on the left at C3-4, I did simultaneously a TCMD here. And because the patient did have shoulder pain, neck pain, some pain at the neck-shoulder junction in that whole zone, I did want to make sure that we were doing everything we could to fully address the patient's symptoms. So a 2-level ACDF could have been considered, but in this situation, I was hopeful again to take motion at one segment only, and only at the segment in this case where she had the anterolisthesis. Here you can see her pre- and post-operative radiographs showing the anterolisthesis at C4-5, and that did measure out to be 4 millimeters in flexion. The angular defect here really isn't that concerning, but with the subluxation and her axial complaints, we did elect to proceed with fusion. And in the MRI, you can see also the foraminal stenosis at C3-4 on the left. These images show postoperatively the ACDF at 4-5 and the beta tricalcium phosphate implant within the vertebral body of C3, one level cranially. Here we did have improvement of the patient's neck pain, although it did take longer for this to resolve, which is perhaps not surprising given the anterolisthesis here, which does suggest considerable facet arthropathy as well. The arm symptoms for her are shown as 0 pre-op, and I think that this points in some ways to one limitation in some upper cervical pathologies with the visual analog scale system. Patients who have C4 territory symptoms will sometimes perceive that to be neck instead of radicular, but her symptoms did extend quite far from the midline. In any event, we do see improvement of the neck pain symptoms, and the patient was pleased with her improvement. The last case here is another example of a standalone TCMD. This is a 32-year-old male who had the sudden onset of severe left shoulder and arm pain extending into a C6 territory. The patient was found to have a soft disc herniation and also unilateral left-sided foraminal stenosis with this. Even though there was foraminal stenosis as well as a disc herniation, we did think we could get the pathology adequately with the access provided by TCMD. And so the patient underwent a unilateral TCMD procedure at C5-6. These images may show well the disc herniation at the C5-6 level. What may not project as well is the association of osteophytes as well. This really is more of a disc osteophyte complex with a superimposed foraminal soft disc herniation. And on the axial views, you get a similar sense of that. Patient underwent single-level procedure and did very well. The preoperative radiating arm VAS score was 9, and that came down to 0. The preoperative neck VAS score was 8, declined to 1 at the 1 month mark, or 2 at the 1 month mark, excuse me, and then thereafter went to 0. The patient was able to return to work in 3 days, and so clearly that early was feeling well enough to do that, and has continued to do well. Note that on this patient we do see a shadow of the TCMD implant at the 4 and 12-week mark, but it's harder to see by the 1 year mark following the surgery. Note also on the 1 year follow-up films that disc height is preserved, and we're not showing here dynamic images, but motion was preserved at this level as well. And so radiographically and clinically, we're pleased with the results here. We also have had a number of poster presentations, the most recent of which was at the ESMIS meeting. The authors on this include Scott Toonstra, one of the co-founders of Transcorp and a talented PA with whom I'm privileged to work, as well as Joe Sclafani with the Milestone Research Organization in San Diego. Again, this is a motion-sparing procedure which allows us to gain access to either a disc herniation or an osteophyte compressing a cervical root. We also can gain access to focal midline soft disc herniations or to midline osteophytes if there's a more focal compression in that zone as well. And finally, the procedure can be performed as a hybrid with ACDF or as a standalone procedure when that's all that's necessary. This was a single site retrospective review of results. These images, of course, show an earlier stage trajectory control device or drill guide being implanted with the anchor pin. Here we see the reamer being used after the decompression has been completed through the channel, and this also is depicting an earlier version of the beta-tricalcium phosphate implants. As you may know, we've switched to a design in which there's a closed cap beta TCP and a much larger space for introduction of autograft. And there seems always to be plenty of autograft available after the harvest using the access channel drill. Here we see some images at the 4, 12, and 52-week mark. Patient demographics are shown, median age of 51 years with a range of 30 to 71 years. On this retrospective review, we did not experience complications. We had a mean return to work of 10 days with the standalone, of 60 days with the ACDF and TCMD. The median return to work was 5.5 days with TCMD as a standalone and 73 days with the combined approach. The 73-day median return to work does seem somewhat long, and I would imagine due to some workers' comp cases or something. The length of stay was an average of 0.6 days for TCMD, an average of 1.2 for the combined procedure. And here we have our overall results with neck disability index and visual analog scale being depicted. We did go from a neck disability index of 59 pre-op to an average of 50 at 1 month, down to 28 overall at 1 year, and the neck and arm visual analog scales also declined at a faster rate, obviously. We did not see any difference in outcome when stratifying by gender, age, comorbidities, or the number of levels treated. When we looked at the neck disability index, we did see the TCMD patients improving to a greater extent at the 1 month mark and at the 1 year mark. The visual analog scale, sorry, here for yeah, sorry, here, this is for a standalone TCMD. Both the neck and arm visual analog scale scores are being shown here, and we did get a significant improvement, of course, from pre-op at the 1-year mark. And similar with the combined approach, we saw improvement for the neck VAS at the 1-year mark. That was significant even at the small group. So again, with the limits, within the limits of a retrospective single surgeon study, we did experience both functional improvement and pain relief from the standalone TSCMD and also with TCMD performed in combination with ACDF. But of course, definitive statements on long-term efficacy will await further work. When we consider doing TCMD, we believe that we're able to use a consistent, reliable approach. The drill guide allows us to make a channel in a reproducible fashion. We're able to save the patient's natural disc. We're able to achieve access to the offending pathology. We are able to extend rather far caudally below the disc space as well. That's one question that comes up with a 1 or 2 millimeter kerrison. Enough of the superior edge of the vertebral body below can be removed to gain access to either disc material or focal osteophytes that are posterior to the vertebral body below. And as I mentioned earlier, we can also gain access to C7T1. As we've shown here, the return to work numbers are a mean of 10 days and a median of 5.5 with a single level procedure as well, which allows people to get back to work much more quickly. And again, it's one of the reasons why patients are often interested in undergoing a TCMD procedure, whereas they would not be if they would have to go through arthroplasty or ACDF. So some patients that might opt for injections rather than ACDF or arthroplasty, in my practice, I find will instead prefer to undergo TCMD rather than continuing with injections. We don't have any long-term implant. The implant does degrade over time as the patient fills in the channel. And that concludes the remarks that I wanted to make on the case series here. I will now turn things back over to Ms. Moley.
Thanks, David. That was a great presentation. Appreciate you taking the time to get on tonight and share your experiences and your case reviews. We are now going to open the webinar up for any questions or additional comments from the audience. So please go ahead. I'm unmuting everyone here and ask your questions. Are there any questions?
Are there any questions or comments?
Okay, if there are no questions, we will end the webinar at this moment. Please feel free to reach out to myself or Dr. Lowry or Chris Welsh with any additional questions or thoughts. Thank you very much for attending our webinar, and have a great evening.